So now let's talk a little bit about the management of estrogen receptor resistant. We kind of a little bit talked about it with high-dose fulvestrant, but I think that clearly, and we talked about everolimus, the mTOR inhibitor. So what are people's thoughts about kind of the current state with everolimus and hormonal therapy? Is it your go-to regimen now for resistant disease?
Yeah, so I told you that I treat based on improvements in progression-free survival, and the BOLERO-2 data showed a close to, depending on which analysis you look at, a 6-month improvement in progression-free survival. We are well aware of what the toxicities of everolimus are, and so as long as you're aware of them, just like when we give chemotherapy to improve progression-free survival, I tend to use BOLERO-2 in patients who have progressed on a type 2 aromatase inhibitor, but I use it like it should be used. It has its own set of side effects, so I don't give the everolimus prescription at 10 milligrams a day and say, I'll see you in 8 weeks. I see them at 3 weeks, which is typically when, if they're going to develop some of the oral side effects or the anemia, we'll see it. You can see pneumonitis that early as well, but I think it should be used. I mean, if you see someone that's taking Xeloda, capecitabine every 3 weeks, then why wouldn't you see someone that's taking everolimus every 3 weeks? And so that's typically how I'll use it. And it is my go-to regimen for patients who have progressed on type 2 aromatase inhibitors.
Lee, what do you say?
I agree completely with Kim. I think the important thing, 2 points. First of all, not to abandon endocrine therapy for cytotoxic chemotherapy too soon. I think many people in the community now give it one and done type of thing. And if you get along, particularly when resistance occurs, is important. So the case where a woman, where the tumor blows through the chemotherapy or BOLERO-2 and then they may have an ESR mutation isn't important. But the other converse is those women who get a year of benefit from their first-line therapy. And they're wonderful candidates for second-line therapy. And with everolimus is one very good option there. I think seeing them early and having a nurse call them, making sure they're taking their medication is really important, particularly important with that combination.
And are you worried about toxicity at all, Ruth?
No, I am, but I just want to, I totally agree with Lee. I mean, I always give endocrine therapy alone, I'll say alone because obviously we may have the CTK inhibitors soon, as first line to see how the disease is going to behave in the metastatic setting. And I actually reserve everolimus for when I believe that the cancer's become resistant. As far as the toxicity, I agree with, once you kind of get used to the drug, I think it's pretty manageable using those steroid mouthwashes and that kind of thing. I think overall patients are generally able to tolerate it once you get them on the right dose.
Yeah, I want to add the pneumonitis. I mean, I didn't see pneumonitis for a long time. And now that I've had people on it for a long time, I'm starting to see it. And just to remember, I mean, I think if someone comes in really short of breath, has a weird-looking CT, it may not necessarily be progression. I want to make that very clear. I've been burned once now with that, and it's kind of embarrassing. It's good for the patient. It's embarrassing for you, but good for the patient. I guess the question is, and I'll give this to Rich because I think that his work has really kind of led to this question, this theoretical question. So someone comes in now on letrozole and a CDK4 inhibitor. And she does well, does the median progression-free survival in that, which is what, about 20 months, 18 months, and now progresses. Again, not to where you need chemotherapy, maybe, has a few more bone mets, maybe a few more soft tissue metastases. How comfortable are you giving that patient, say, exemestane and everolimus after? Would you do it?
I think, sure, there's no reason not to. The survival data from the Paloma-1 Trio 18 study showed that there was a slight 4-month difference, but importantly, there was no detriment to, after CDK4/6 in the frontline setting. And I'll be honest, while the BOLERO-2 data, I'm a little disappointed there isn't a survival benefit. Certainly, it is an option before going to chemotherapy because, let's be honest, chemotherapy helps these women, but it's not a panacea, for sure.
Yeah. So, I mean, Kim, do you agree with that? I mean, I guess the question out there, I think, is going to be, you've had CDK4 plus letrozole. Why should you go on exemestane and everolimus? You've had one targeted therapy. Why do two? As we know, we're laughing, but that's going to be a question people are going to ask.
I think a bigger question is going to be for people who get first-line CDK inhibitors, is there benefit to continuing it and switching the endocrine backbone?
Right, that's going to be the real question.
I mean, I don't think we'll be allowed to use it until there are trials. I know that Novartis is looking at that kind of continuing versus stopping into the second-line setting with their CDK inhibitor, LE01. So I don't see any reason you wouldn't. I want to give my best therapy that's been demonstrated in the first-line setting. I want to give my best therapy that's been demonstrated in the second-line setting. I just don't see a detriment for patients. It's not,
We don't
we,
know.
yeah.
We don't know. Okay.